Good morning and welcome back to Preserve Health Talks. My name is Dr. Ira Pearlstine and my co-host, Dr. Leah Ginn, is away today on vacation, so it's just me and my guest. And today I'm joined by Dr. Luis Velazquez, an accomplished community psychiatrist who has only been in this area 1 month, slightly more than 1 month today, with a truly distinctive journey. He was born and raised in New York City, I believe.
Yeah.
Dr. Velazquez trained on the East Coast, primarily in New York, in the Bronx, Mount Sinai, and then Columbia University, before practicing for 6 years in Maine. So he's kind of a Mainer. After 9/11, he sought a change in pace, relocating himself and his family to New Mexico, what he called his family adventure. So he skied the Rockies and he's immersed himself in the beauty of the high desert, but ultimately he returned to the great state of Massachusetts to be closer to family and provide the best educational opportunities which he had for himself, for his children. He describes himself as an eclectic psychiatrist with experience spanning inpatient community mental health centers, residential treatment programs, and substance use treatment. Known for more of a conservative approach to prescribing medications, he favors thoughtful and often non-pharmacologic strategies whenever possible. And for more than a decade, he's been a leader in transcranial magnetic stimulation, better known as TMS, cutting-edge therapy for depression, obsessive compulsive disorder, and even used now for smoking cessation, offering patients the hope of fewer medications at lower doses. But with a deep respect for scientific evidence and the compassion to meet patients where they are, he has embodied the mission of psychiatry as both art and science. Pretty good introduction. Please join me in welcoming Dr. Luis Velazquez to our show, Preserve Health Talks. Good morning.
Good morning.
And welcome to our show.
Thank you for having me.
So you've practiced psychiatry in many different settings, from Maine to New Mexico to Boston, and now here in Stuart, Florida. How have practicing in these different regions shaped your clinical perspective of psychiatry?
Well, you might say it's a bit of a professional odyssey going from one extreme to the other, and I'm very grateful for my travels and travails throughout. I've had a good life like that professionally. We live in an amazing country full of opportunities. My professional trajectory exposed me to scientific, social, historical cross-germination. After medical school, I did my psychiatry residency and fellowship in child and adolescent psychiatry in New York, which is the global nexus of great institutions, thought leaders, learning, particularly in psychiatry. I remember reading on the wall a poster in my Department of Psychiatry offices at Albert Einstein, a quote from a second century rabbi: "Teach yourself to say, 'I do not know,' and find yourself a teacher." And that has become something of a mandate for me throughout my career. The best physicians are those physicians who have the humility to know what they don't know and ask for help and ask for direction. It's troubling to me when you come across people who seem to want to know everything and close themselves off to learning. And there's lots of people who want to know lots of things or pretend to know lots of things, and lots of people who claim to be experts. And I can be a good listener, but in the end, I always quietly ask myself where's the math? How is it that the information presented to me is good information? Because every venue can present you with both good and bad information. So when you're learning stuff, it's important to know that what's being taught to you is valid versus not so much.
Sure, and that is the final phase of learning, when you know what you don't know, because that's where, particularly as doctors, you get yourself in trouble.
Right.
I think I might know this, but if you know what you don't know, then it's either best to refer or learn about it. And with medicine, folks, it's really about lifelong learning. If you're not a lifelong learner, you don't make a very good doctor. So medicine changes.
I so agree with that.
Yeah.
Yeah.
And the field of medicine has expanded so much. There was a line that I saw during a conference one time, and it said, if you read 2 articles a day that came out in medicine at the end of a year, reading 2 articles a day, you would only be 165,000 years away in catching up to everything that you could learn in medicine. That's how the field of medicine has expanded. And with artificial intelligence, it's expanded even more rapidly.
It's daunting.
Yeah, it's daunting. But even though it helps us, you still have to know what you don't know and focus in on what you know.
Agreed.
So you call yourself an eclectic community psychiatrist. I don't even know what that means. Explain that.
Well, what is psychiatry? It's a medical discipline, as would be pediatrics or internal medicine or surgery, but it's one that has been struggling to define itself for over a century, since its inception in modern medicine, born out of psychiatric hospitals or asylums in Europe at the end of the 19th century. Disorders of the mind were initially seen as disorders of the neurological system, of the brain. And the majority of psychiatric illnesses do not have things you can point to either on an imaging study or under a microscope that can say, oh yeah, that's the problem. You know, we can identify degenerative disorders through histology, through an autopsy. We can identify large ventricles in the middle of the brain that are consistent with schizophrenia. But for the most part, most illnesses do not have something that's easily identifiable as the cause of an illness. And then in medicine, lots of things look like lots of things. So when someone has a fever, we don't automatically think, oh, he's got fever disorder. It's important to figure out, well, what's causing that fever? Likewise with shortness of breath or fast heart rate, that's a symptom, that's not a diagnosis. So in psychiatry, that's much more difficult. Because we are not just the sum of our biology, of our genetics, of our physiology. Our organisms interact a lot with the world around us. You know, we have evolved and we continue evolving. And as a psychiatrist, I need to consider the biology as much as I consider the psychology and the social circumstances in one's life.
Right. And medicine has changed. If we go back 3 generations, the 1940s, we treated symptoms. You had a fever, we treated fever. You had a rash, we treated the rash. Step it up to the next generation, we treated diseases that cause those symptoms. Now we're at the stage in our generation where we're treating the causes of the disease. So what causes the disease that we're treating that manifests as the symptoms? So we're going to continue to improve on that. And if we take that, for instance, and let's say we combine it with what the ancient Chinese and other cultures, but not our culture, has called the mind-body connection, we know that many disease processes are related to psychiatric illnesses. And this is...
It's an artificial distinction, you know, the mind and the body. It's one organism. It's just different manifestations of the one.
Right, but let me tell you where I'm going with that.
Okay.
Unfortunately, insurance companies don't see it that way.
That's correct.
And insurance companies rarely pay for psychiatric care. And I find that infuriating, as more than 10%, some people say even as much as 15%, of our society here in this country have treatable psychiatric illness, and it's not covered. As a psychiatrist, that must, to use lack of a better term, drive you crazy. But how do you deal with that?
Well, because I've been eclectic, meaning I've worked in rural settings, in urban settings, I've worked in very socioeconomically disadvantaged communities. I've worked closely with Indian reservations in New Mexico. I've worked in affluent communities. So I've had a exposure to various expressions of human existence. And there's a commonality with all of them, but there are also differences. And what I've learned is that you need to treat people in the circumstances they come to you in. And the fact that insurances don't want to pay for treatment, well, insurance is a business. And not that to some degree medicine isn't a business, because we all need to make our livelihood. But one hopes that physicians have gone into medicine for more than just the livelihood, but that it gives them a sense of accomplishment and a reason to get up in the morning, that they enjoy both the science and the caring of humanity. So one manages. The insurance companies do not have to hold you back. You have to get creative. When I lived in Maine, it's a very poor state, 43rd economy out of 50. So there wasn't much of anything to work with insofar as providing people more than medications. And that's the problem, that insurance companies are very reductionistic. They prefer that we just identify a disorder and give a pharmacological intervention, and they're done with it because it's cost effective from their perspective. But it's not cost effective for the patient, because I know that there's lots of overdiagnosis and over-medication. And I'm not against medication, and I'm not against, having a difficult talk with a patient or a family about, you've got this biological illness and it is a lifelong illness and it needs to be managed. That's never an easy conversation. But at the same time, you want to provide them with something hopeful, saying there are things you can do that are not medication-based that can help you live a better, more productive life. Let's consider the dementias. Increasingly so, dementia is being seen as a disorder of metabolism, of glucose metabolism, some referring to dementia as type 3 diabetes. And to me, that's, I guess, intellectually exciting, in that they're coming to these insights of what the mechanisms are that cause the cascade of events that results in dementia, either Alzheimer's or Lewy body. There are things that can be done in lifestyle that can slow the progression of what might be the inevitable. Because if you live long enough, we're all going to get something. We all have an expiration date. But what we want is to provide people not just with a long life, but a meaningful life. Not just a lifespan, but a health span.
Well, two questions in follow-up to that statement. Do you think we're seeing more dementia based on either chemicals that we're ingesting, metabolic changes, or do you think people are living longer because we're better at treating cancers, we're better at diagnosing heart disease earlier on, and treating those disease processes so they live longer in order to get dementia?
That's a great question. I think probably there's multiple answers to that. If we consider the blue zones around the world where people live past 100, people who live past 100 in those places like Okinawa and Costa Rica and Sardinia, they have clean living. They walk a lot. They are humanly connected. They don't have exposure to severe stress and angst like people who live in big cities might. And they eat very clean food, not doused in chemicals or preservatives, and they eat whole foods. So I think there's something to that. I mean, the U.S. right now has an obesity epidemic, and the results of that obesity epidemic are going to be that even if they can keep the organism alive to 90, it doesn't mean you have a great quality of life if you're not able to find meaning in those 90 years. So I think there's a lot we can do, not just as psychiatrists, but as primary care physicians. We need to be educating our patients to live cleaner lives, healthier lives, because that will be a value added. The longer you live, the longer you want to have quality life. You don't want to be restricted to a wheelchair because you get winded easily, and you don't want to start forgetting things and forgetting your memories.
Now, you call yourself pharmacologically conservative, but yet you use medications. Do you feel that as a psychiatrist, our medical community over-treats people with pharmacologics? That's the first part of that question. The second part of that question is, unlike yourself, many psychiatrists say, well, I will prescribe your meds, but you need to see a psychologist if you want to have someone to talk with about your problems. You seem to be unique as a psychiatrist in realizing that human interaction is important because of your pharmacologic conservativeness.
I think
Explain that a little.
I think perhaps because I am the last generation of psychiatrists to have been formally trained to do psychotherapy. Increasingly, we see that psychiatric residencies do not teach much psychotherapy to psychiatrists because their role is increasingly just to provide medications. And as you know, every hammer finds a nail. So we need to worry about sending people out with a single skill set, because then that'll be all they can use. And you need to have more eclectic tool set, because yes, depression does exist, but existential sadness is not depression. And every time you see someone who comes in and says, I'm depressed, it's important to make sure that it's not appropriate sadness based on life events, which will pass.
As an example, a grief reaction
Absolutely.
from death of a loved one.
Absolutely.
People need that time to grieve. If you mask it, then they don't achieve full closure.
There are some people that are biologically primed to experience what used to be called melancholia, an old-fashioned term for depression, where the organism wants to shut down, doesn't want to eat, can't sleep well, doesn't want to shower, that has no interest in pleasurable activities, and their life might be perfect, but somehow the organism doesn't want to move forward. That's biologically driven depression. And then there are some people that are highly resilient and their life around them is just terrible, but somehow they're almost Pollyanna. They just find something to smile about regardless. Those are very resilient people. And most of us are somewhere in between of how we function with the vicissitudes of life. We don't have to medicate everyone, but we need to talk to them about what we can do for them if not medication. Medications are not without long-term consequences. A lot of them have very significant side effects. The first antidepressant was found accidentally in the treatment of tuberculosis patients. They noticed that iproniazid, which was going to be used for tuberculosis, also made tuberculosis patients not be depressed. So a very serendipitous finding. And then a decade later, in the study of anesthesia medications, they found that chlorpromazine helped people not get agitated or hallucinate, schizophrenics. So that's all good. That's all good. So we have, acute solutions to acute problems. But we should ask ourselves, are we doing things as a society that's causing more and more people to have these problems?
Well, as a society, we're seeing more violence. We're seeing more stress. We're seeing people in a hurry to get nowhere, as George Carlin, the comedian,
Right.
said. Do you feel that social media has been a big player in an increase in depression and anxiety, particularly in adolescents in this country?
That is the worst kept secret around. I think we all know that's true.
Well, let's bring it out in the open.
Jonathan Haidt published a book called, Anxiety, and he's written extensively on the toxic effects of social media, pinpointing 2012, the year that smartphones became widely used by preteens and teens, as the year when we began to see more and more youths expressing feelings of depression and anxiety and despair. And the numbers have been compelling. Yes, we were not designed, we did not evolve to have a constant flood of data. And for an adolescent, the data is usually, do you like me? Do I look nice? Do people find me appealing? And especially with adolescent girls, that's devastating. And then the toxic belief systems that might lead an incel to want to commit violence. This is not unrelated. So absolutely, I think that we need to put brakes on our exposure to not just the content, but the quality of the data that is ingested. And families and communities need to play a role in deciding what data is acceptable. Just because we believe in freedom of expression does not mean that all expressions of value systems and ideas are valid for your community. I can respect whatever value system you have if you live your life, but you got to let me live my life and let my children have my value system. So we live in a very interesting time where everyone's assuming that because we have an internet and because we have social media, that whatever you put out there has to be validated. And it doesn't. We can disagree. We need to find a social contract that we can all agree to, because not all value systems are equal or valid.
Well, social media obviously is here to stay. So if you were seeing an adolescent patient who lived by everything you read on social media, and one of your recommendations, I'm sure, is you need to limit your screen time.
I treat it like an addiction.
Yeah.
And it very much
How
is
do
an
you
addiction.
limit screen time?
Well, if you're...
How do you do that?
I think parents can do that by turning off the Wi-Fi in the home. And they could also, parents forget that they're parents sometimes, and family life does not have to be a democracy. I think a healthy family of young and middle school children is necessarily a benevolent dictatorship.
I love benevolent dictatorships when it comes to family.
Right. You
Right.
don't have to be obtuse about it or mean or heavy-handed. You can just say, no, sorry, I love you, I'm the boss, and you cannot listen to that toxic stuff. Because, and you know what, parents have to have disagreements. You have to be real. You got to pick and choose your battles carefully. You have to understand that a society changes and you're not going to like all the changes. So you got to be sure about what you're going to pick a fight about.
I want to circle back to that on another show.
Sure.
But we're going to run out of time if I don't get another couple
Understood.
questions
Sure.
in. So I want to focus on some what used to be alternatives and now have become mainstream. And one is TCMS, Transcranial Magnetic Stimulation. Can you tell our listeners a little bit about TCMS, what it is, and how it's used?
It was invented in 1985 and approved by the FDA in 2008. TMS, Transcranial Magnetic Stimulation, basically is a magnet, like an MRI. They put a lead on top of your head and they point the magnetic pulse at the part of the brain that is responsible for your affect, for your moods. And it's highly effective. When it comes to medications, only 60% of people respond to medications for depression. That's kind of bad because the placebo response is 30 to 40%. So 60, it's good, but it's not great. And then of those 40%, you can go on a succession of other medication trials that have different receptor profiles. But with every succeeding trial, it's less of a response and less of a response. So by the third trial of medication, you have a very demoralized patient who says, you're not helping me, I'm just going to give up. Meanwhile, if you do TMS, the response rate is 80%.
And
of those 40%,
and
the hard
and
to
it
treat.
works by stimulating neurochemicals like activating dopamine receptors. How does that
You know
work?
what?
How does it work?
I'm not going to pretend I know the answer to that because I don't think anyone knows exactly the answer to that. But it works. It's 20-minute treatments for 36 sessions, and you have an 80% response rate.
Insurance usually cover it?
It does now because, you know what? It's more cost effective than repeated hospitalizations. And the prices come down some because it's much more available too.
Do you offer that?
I do offer that. We'll be starting that up within a month.
And you do it in your office?
We will be doing it in the office.
Okay. And are there any side effects to it?
You'll hear a ticking sound, and it may give you a bit of a headache. It doesn't actually touch you. It's just a magnetic pulse. But some people will feel like a sharp pain on their head, as if it's like a woodpecker, pecking them on the head. But that's because the skin cells in the cranium have pain receptors, whereas the brain cells don't have pain receptors.
And any contraindications like seizures or?
Yeah, it's contraindicated if you've had seizures or if there's any ferromagnetic materials in your head because it's a magnet.
So in other words, if you've had, let's say, an aneurysm clipping or something like that,
Then it's
contraindicated.
Absolutely.
Okay. All right. Well, I want to leave on one question, and I've got to make it a good one because you've been such a great guest. Psychedelics. We hear a lot about ketamine and mushrooms and things that are now used kind of off-label, or perhaps very off-label, to treat resistant depression and maybe even bipolar illness. A couple comments on your use or dislike of psychedelics.
Yeah, I don't dislike them. I'm learning about them. I think that there is a trend in the community, not just with psychiatrists, but physicians in general, to want to be cutting edge and try the best new exciting thing. And I think that we should all have the ethics, the values, where we inform our patients up front that what we're doing is on label or off label, meaning FDA approved or not approved, meaning consistent with accepted algorithms of treatment or not. Patients have the right to know that. They have the right to know that they want to be cutting edge with you or not. And not that I haven't used medications off label. I think most physicians have. It's a matter of being honest and communicating that. In terms of psychedelics, it's a little bit problematic for me knowing that these are euphorogenic substances that were club drugs and illegal. And the way, let's say, ketamine works is you've got to come in twice a week, and it's unclear as to whether or not you can stop coming in. And I have to ask the question: is this simply coming in for your, twice a week hit of a euphoric medication that covers up the underlying grief or sadness or depression? And it's not as simple as people say it works for me, because again, there are consequences, like the old story Flowers for Algernon, where something works wonderfully at first, but then there's a price to pay.
Gotcha. It's been a pleasure having you on the show.
Thank you.
I'd like to bring you back. I only covered about half of what I wanted to talk about, and we're already into it for like almost 30 minutes. Would you come back?
Absolutely.
Do another episode with
I'd love
us?
to come back.
Okay. Well, thank you, Dr. Louis Velazquez.
Thank you.
And welcome to our community.
Thank you much.
This has been another episode of Preserve Health Talks. I look forward to seeing you on our next episode. Have a nice day.